My name is David Kooby. I'm a surgical oncologist at Emory University School of Medicine. I specialize in complex gastrointestinal surgery and focus on upper gastrointestinal tract. I'm full professor of surgery. I am the vice chief of staff at the Emory St. Joseph's location and the surgical lead for the northern arc in the Emory system. So patients will come to see me not infrequently with pancreatic tumors. And first we have to decide if they're candidates for surgery, but then they'll ask about minimally invasive approaches. Can you get my tumor out without making a big incision? This is an area near and dear to my heart. We, as a collaborative group called the Central Pancreas Consortium, published some of the early multi-center comparative data looking at minimally invasive versus open approaches for pancreatic tumors. And the first thing you need to know is, what is the extent of the tumor, what kind of shape is the patient in, and what is the skill level and technical abilities of the medical center and the individual surgeon before proceeding. In reality, many of these procedures can be done minimally invasively, provided the tumor extent is not so advanced that it's involving major vascular structures or growing from the pancreas into other structures. So the simple answer to the question is, am I a candidate for minimally invasive surgery? The answer is most of the time, yes. And, based on, again, the individual surgeon preference and the situation with the person, that's how, we would decide. So what are some of the advantages? Well, with a minimally invasive approach, the perioperative pain could be reduced. The blood loss, actually, because of the visibility, you have a camera that's right up against the tissue that you're looking. And not only that, you can look underneath the pancreas and see structures that you cannot when you directly have an open abdomen and you're looking straight down. You can reduce blood loss, you can get a finer dissection, and you potentially can have a shorter hospital stay with faster return to normal function, faster return to work. And for patients who need additional therapy, such as chemotherapy, if the recovery is a little smoother, well, then they might be able to start adjuvant chemotherapy sooner. There's actually published data on this for Whipple procedure for patients with adenocarcinoma, suggesting that there might actually be even a slight survival advantage, but that was not done in a randomized situation. So what are some of the disadvantages of the minimally invasive technique? Well, not every procedure is amenable, number one. You may get into bleeding that now gets to be a little more difficult to control if the belly's closed and you're working with laparoscopy or robotics. In addition, you may get lost. You may be working in an area that you're not sure that you're in the right place. It doesn't happen often, but it certainly can. You can get confused and transect the wrong structure, but that can also happen in open surgery. So we have to temper our enthusiasm for sort of novel and newer approaches with understanding at the end of the day, we really need a patient who's in good shape with their tumor out, with optimal margins and adequate lymph node dissection. So if you can do it that way, if you can do it with the minimally invasive approach, then have at it. And if you're better off doing it in the open approach, either because your skills are not there or because it's not right for that particular patient, then you should take that into account as well.